talking, somebody else take over. In any case, this morning we are offering continuing education credits. I put the link in the chat. I will put it again and I will share it a couple times throughout the hour. Towards the end of the hour, I will share a different link that is an opportunity for you to give us some anonymous feedback on how these sessions are. It's just a handful of questions. And we use that to plan these. And if you haven't done so already, go ahead and mute yourself. The session is being recorded. And I think that is all that I have.
Okay, great. And today we have presentations from Imani Ransby, who's going to give updates on the area. Dr. Mira is going to give COVID updates, and Frank Light is going to give dental updates. So we'll go ahead and get started with Imani Ransby.
Brian and Imani, before Imani gets started, I just wanted to make a very brief announcement. First of all, I would like to introduce Gabby Wade. She is our new HIV coordinator. We are able to purchase some OraQuick rapid HIV tests if the tribal nation is interested in those. But please let us know if we have a pretty tight turnaround and we need to know by close of business today. So if you're interested, shoot us an email or you can send us a chat privately. I just wanted to put that out there. We had sent an email around, but I also wanted to announce it just in case we were missing anybody. But with that said, I'll turn it over to Imani.
Bye. Thanks, Christy. So hello, everyone. I'll just be providing an update on the COVID-19 epidemiology in the USET region, which will just include taking a look at the aggregate data that's being compiled on a weekly basis. I do want to note that we did not meet last Friday, so the last update given was from 9/11. So therefore, the changes being seen on the next slide are over a 2-week gap period rather than a 1-week period. So the numbers displayed in the table were obtained from the 26 sites that are currently reporting COVID-19 testing data to IHS or the Indian Health Service. So the numbers in parentheses are from the last update from 9/11, which I mentioned, while the numbers to the left are from today. And the total number tested increased from 25,208 to 27,109. While the number positive increased from 1,932 to 2,012, and the number negative increased correspondingly from 22,538 to 24,176. So still seeing increases there. So the cumulative incident rate within our 13 USET states is currently presented on the slide. As you can see, we do provide a USET state rate, a county rate, and then the United States rate for comparison. I do want to note that the USET county rates are produced from gathering information from purchase and referred care delivery areas. So that's something to keep in mind. And so as we can see, the USET county or per rate or cumulative incident rate is highest, followed by the USET state rate and then the United States rate. Overall, we are still seeing a steady increase across the board, with the USET county rate increasing from 263 per 10,000 to 270 per 10,000. The USET state rate increasing from 238 per 10,000 to 247 per 10,000. And then the United States rate increasing from 201 per 10,000 to 210 per 10,000. Excellent increase there. So lastly, I want to just mention that we are still offering the USET TEC COVID-19 surveillance tool to assist tribal nations with tracking their cases and contact tracing. If you are interested, please feel free to contact us at usetepi@usetinc.org. and we can get you set up. In addition, if you do require general assistance, please feel free to reach out. Thank you.
Great. Thank you, Amani. Do we have any questions for the TEC team? If not, we can go ahead and move on to Frank Light for his presentation.
Hello. Let me get my PowerPoint up over here. All right, can you see that?
Yes.
So basically what we're going to talk about for the next 3 hours or so is, I'm kidding, it's only 2.5. We're just going to talk about some interim guidance for reopening the dental clinics. So ultimately you have to look at the CDC guidelines, but I've got some things we can look at. So our purpose today is really just talk about assisting the dental programs in reopening efforts. Your dental directors want to exercise due diligence and thoroughly review recommendations from OSHA, CDC, and IHS. It'll help you build those guidelines for opening your clinics. You want to stay up to date with any federal or state and local changes as they require or they change in dentistry requirements. Again, it'll just help you stay abreast of anything that you need to be following. So obviously we know that COVID-19 is thought to be spread primarily through respiratory droplets, but airborne transmission from person to person over long distances is not typically likely. It's also shown to persist in aerosols for hours and some surfaces for days. COVID-19 may spread by people who are asymptomatic, and I've heard both things lately, that if you're asymptomatic, you can't spread it. But the CDC says if you're asymptomatic, you still can spread the COVID-19 virus. Obviously, we have risk in the dental arena. We have instruments, high-speed instruments that cause aerosols, that cause visible spray. So we want to make sure we're using the correct surgical masks. Although the good news is that there's been no report of any COVID-19 clusters in dental settings in the US in 2020 so far. Some things to consider: highly recommend dental programs align operations with current CDC guidelines. That'll again help you make sure you're on the right track. You want to have a phased approach to opening, which I'll go over in just a minute. If there is a COVID surge in your area, you want to reduce or terminate non-emergent and elective procedures just to help get around that. Elective procedures should be periodically assessed for are they really needed right now, or can we get away with waiting on these? You just want to consider the risk-benefit when providing this elective care. And again, review your CDC guidelines as they may change from day to day. Education and training for your staff. You want to provide your dental staff with job or task-specific trainings on the prevention and transmission of infectious agents. Infection control training and PPE. I know we keep hearing about that, but it's important. Your staff should have an infection control competency training at least annually. You want to try and coordinate with other medical programs. A lot of dental programs are in the same building as other medical programs. You want to work with other dental directors and other medical directors. Work closely with those colleagues in the allocation of PPE for staff, for patients. Maybe decide who's going to do the initial screening when the patient walks in the door, who's going to provide masks for those patients, that kind of thing. Okay, our three-phased approach to reopening recommended by the CDC. Phase 1, you're going to begin slow return to reopening by providing level 1 and 2 preventive services. Once you hit phase 2, you can provide level 1, 2, and 3 basic oral health services as well, including most restorative, operative dentistry, and high-speed handpiece usage. Phase 3, you want to provide levels 4 and 5 services as needed. Disinfection, obviously, that's an important thing. After A patient without suspected COVID-19, there's no longer a 15-minute wait time to begin disinfection of the room. Again, refer to CDC interim infection prevention and control recommendations. If you have a patient that's in your chair that's suspected to have COVID-19, you want to wait for about 15 minutes for the air to circulate out of that room before you begin disinfection. Use of rubber dams. IHS recommends the use of rubber dams with an isolate or iso-dry, and the use of appropriate isolation in the building wherever you can with high volume evacuation. This will drastically decrease the aerosols and splatter that are spread around. Dental hygienist risk mitigation. Dental hygienists have been listed by various sources as the profession that is the highest risk for contracting COVID-19. So to mitigate that, what we want to do is we want to assign a dental assistant to assist with high volume evacuation. And then your dental hygienist must use fit tested N95 respirators. That will help mitigate that risk for them. Obviously, we want to do minimally invasive dentistry. Dental programs are encouraged to use teledentistry whenever possible. Teledentistry is highly effective in providing temporary home-based solutions, re-cementing crowns or making an appointment, having them get an antibiotic, something like that. Just try and do whatever you can to help defray the spread of the COVID-19. OSHA, utilize the latest OSHA guidelines for dentistry employers. You want to look at airflow in your building, airborne infections, and isolation rooms if possible. Engineering controls, these are things you can do if possible. You want to consult your HVAC professional and investigate possibly increasing infiltration efficiency to the highest level compatible with the system you have in your building. You want to safely increase the percentage of outdoor air that you can. Limit the use of demand controlled ventilation, which means you just don't want it to kick on the ventilation because it gets too cool or too hot. You want to be able to control that throughout the day better. Also consider portable HEPA filters within the vicinity of patient chair, and consider upper room ultraviolet germicidals as an adjunct to the ventilation. Sorry. Where'd I go? There we go. With your patients, obviously, social distancing is important. So patient placement is important when you're doing this. When feasible, place patient's head near return air vents away from the corridor. The patient volume, you want to make sure you don't have too many patients in the building for the space you have available. And just make sure that those patients can be treated safely in that area. Obviously, make sure that your PPE is fully stocked to handle your patient care. Patient screening is something that you can do easily as well. You can do a telephone screening initially with certain questions that you can have. The documents that were provided with this gives you some questions that you can ask as well. If symptoms are reported, delay the care, obviously. Remember to let patients know that their questions and temperature will be taken when they get to the office again, just to make sure that they haven't gotten worse or contracted it since you first talked to them. Remind patients and guardians that only essential people are allowed in the treatment area. And then consider having patients wait in their car until you're ready to seat them. That will also help deter the spread. All right, are there any questions? I know that was really quick, but are there any questions for me?
I have a question.
Sure.
That was a great presentation, by the way, very comprehensive.
Thank you.
So, you know, the teledentistry, is that something you can bill for? And the reason I'm asking is because, you know, one of the pushbacks we had with telemedicine, of course we had to do it because there was not an option, but then when things starting to get relaxed, we noticed that people wanted us to go back to the face-to-face because of billing issues, and you could bill better or whatever, bill more. So would that like affect you or?
You know, I can't answer that today, but I know that several travel nations, as well as several companies that we've worked with out in California, are working on a teledentistry plan. So I'm going to reach out to them and see what I can find out, because that's a really good question.
Thank you.
Any other questions for Frank?
So one comment, and maybe you mentioned it. You know, now that the antigen test is coming out, or it's already out there, I'm not sure. I mean, we don't have it yet, but it's coming out soon. And I know IHS sites have some facility to get it. So we were discussing that today, and one thing I recommended, I mean, this would be a great place to use in the dental clinics. Like, you know, test everybody with an antigen. It's not a perfect test. It's not as good as PCR, but it's better than nothing. And if you could use, and it's cheap. Apparently, it's going to be, you know, a couple of bucks per test. So I think we should consider that. I don't know what your thoughts are on just using that to screen patients when they come in. And if you find one positive, you know, you go home. Unless you have an emergency, and then you go to a place that can contain that situation a little bit better.
Yeah, that's a great idea.
Hello?
Hello.
Can you hear me?
Hey, Dr. Park.
Oh, hey. I'm sorry. I was trying to talk earlier and sorry. Yeah, I just want to go back to teledentistry real quick. What was the original question? I'm sorry. Because there's some states like Texas doesn't allow you to bill, doesn't allow the teledentistry, and we've ran into some problems, especially with reimbursement, but I missed the first part of that question. I didn't know what
He was asking about,
were
you want to
we to bill?
So the question was, can you bill for these services of teledentistry at
Gotcha.
a rate
Okay.
similar to the ones that you would if you had a patient there?
Right. Yeah, and just like Frank said, yeah, they're working on it, and we ran into trouble. Like I'm in New York, and we don't. It's just they're working it all out, and but like I said, some states like Texas don't allow it, so we really haven't. And the reimbursement, when they do reimburse, it's very low. But it was a great question, and just to back up Frank, but and also Frank, nice job on the presentation as well.
Thank you, sir.
Okay, hearing no more questions, we can move on to Dr. Mara's presentation.
Okay, thank you, Brian. Now I chose a couple of topics here. I'm sorry for Dr. Brown, because I think this is the third time he's going to hear this. So we can let him take a break. Anyways. So a couple of interesting things. You know, the literature is flooded with stuff about COVID, and it's hard to tease things out. So I try to choose the ones that have some practicality or that are physiopathologically very interesting. So the first one is the question that these authors are trying to answer is, are patients with liver disease at a higher risk of complications from COVID-19? You know, it's on the CDC list of people, I think it's on an intermediate list, but we don't really have any data, and data started coming out in a couple of papers in the last week or so. And the reason I'm in particular interested is because we have a Hep C program. We see a lot of people, I would say 90% of the patients I see have chronic liver disease. So what these authors did, they looked at 37 healthcare organizations in the US. They mined their electronic health records. This was all, of course, de-identified. And they classified the patients that they looked at into two groups. They either have liver disease or they don't. And the criteria for having liver disease was an ICD-10 code of cirrhosis, or an ICD-10 code that said chronic liver disease. And what they looked at, and of course, important, all had to have COVID-19 confirmed by a lab test, right? So these are COVID-19 positive patients with and without liver disease. And they looked at mortality, hospitalization, up to 30 days after the COVID test was positive. So here you can see the table, which they're always complicated. So let me walk you through the main points. The first thing is that they identified 250 COVID-19 positive patients with liver disease and 2,500 without liver disease. The second thing that they found is that when they looked at the characteristics of these patients, because remember, this is not a randomized study or anything like this is a retrospective review, that the two groups were pretty different. So it was difficult to compare. And that's why they did a propensity matching analysis to match, apples to apples and make sure that you were comparing the right thing. And what they found is that patients with liver disease have a much higher mortality, 12% compared to 4% on those without liver disease. And when they looked at hospitalizations, 48% risk of hospitalization versus 36%. So in this slide here just summarizes in a little bit more detail what I just mentioned. 9% of the patients that they found had liver disease out of the 2,780. Interestingly, all of them had elevated LFTs with or without chronic liver disease. And that's something that we see with COVID. Most of our, if not all of our patients who are admitted, they'll have elevations of ALT or AST, or both. And that is because the virus, apparently there are ACE2 receptors in the liver, and the virus can cause liver inflammation. So patients with liver disease had higher mortality, higher risk of hospitalization. And when they looked at the subgroup of patients with liver disease with a diagnosis of cirrhosis, the mortality was even higher compared to patients without liver disease, which is not surprising. We know that patients with cirrhosis, when they have any acute liver insult of any kind, they tend to do worse than patients without cirrhosis. So they conclude that liver injury can be seen in most patients with COVID-19, meaning elevated liver enzymes. And when you have pre-existing liver disease, it increases your risk of mortality and hospitalizations. So what is the practical message here? When you see a patient with COVID-19, if they have a diagnosis of chronic liver disease, you better look at that patient a little bit more closely, maybe follow them. Doesn't mean, excuse me, face-to-face, but you need to call them and make sure they're doing okay. Right now, we don't have any particular intervention to decrease this risk of hospitalization, but I think you should be on top of those patients and intervene quickly if they decompensate or they do not do well. So the other study, switching gears a little bit to risk of vertical transmission of COVID-19 from mother to baby, these authors looked at breast milk, if breast milk has the virus or not. And they did a very interesting study. They advertised through the internet, web pages, etc., in the country. So to any female who was COVID positive and was breastfeeding, if they wanted to participate in the study. And of those who wished to participate, they requested them to obtain breast milk samples, which were self-collected by the patient and mailed into the study center. And they took their word that they were COVID-19 positive. I mean, they did not perform an extra test on these patients. They did validate a PCR to detect COVID-19 in the breast milk, as well as a tissue culture to culture the virus was validated in their laboratory. And they also did another experiment, besides looking at does the breast milk of these COVID-19 positive females have COVID or not. They did some experiments in which they spiked the virus, a laboratory virus, into milk, and they pasteurized some of the aliquots, and they did not pasteurize others. And then they looked to see if they could find the virus after pasteurization. So they were able to recruit 18 women. The majority were white, non-Hispanic. The ages of their babies were between newborn and 19 months. They were, of course, all breastfeeding. And although there were 18 patients only, they had 64 samples of breast milk from these patients to evaluate. And then this chart, which seems very complicated, is just a list of the 18 patients. We go from the y-axis 1 through 18, and on the x-axis, you see how many samples each patient provided. And if the box, the little square here is open, it means the patient was non-symptomatic. And if it's dark, it's symptomatic. So, this patient was asymptomatic when she gave this sample, but was symptomatic when she gave this sample here. And you can see that they obtained many samples on each patient. So what did they find? Only one breast milk sample had detectable SARS-CoV-2 RNA. And on that particular patient, that sample was positive. The breast milk was positive the same day that the patient became symptomatic. On that same patient, samples taken several days later, 12 and 41 days, did not show the virus on the PCR test. There was no replication competent virus in any sample, meaning they could not culture the virus from any of the breast milk samples they received. And when they pasteurized those aliquots that were spiked with the virus, they could not detect any virus after the milk was pasteurized. Neither the RNA of the virus, nor were they able to culture the virus from those aliquots. But on the non-pasteurized milk aliquots, and remember this, they spiked the virus. This is not the breast milk from the mom directly. They were able to detect virus in one of those mixtures. So in summary, what they, basically their conclusions are that breast milk is probably an unlikely source of infection for an infant, which validates our practice that we are encouraging moms to breastfeed their babies. Of course, we explained that there's a risk that the baby can get infected, not through breast milk in particular, just through the contact, but that the risk is low and probably greater than the unwanted effects of non-bonding mom and baby during that critical part of their lives. And that pasteurization seems to work. If there is any virus there at all, if you pasteurize the milk, it will kill the virus. Anyways, limitations of the study, it was a small sample. This was not a randomized study. Patients reported, self-reported PCR positivity, and they self-collected the milk sample, so that was not standardized like you would in other research studies. But I think this is the only information we have. It's good information, and we will need more studies, but it reassures us that vertical transmission is not that common or feasible. Okay, switching gears to another study. This, so you all know that thrombosis of the veins in the lower extremities and thromboembolism is very common in patients with COVID-19, 10 times more common than any other critically ill patient with another diagnosis. And the problem is that for diagnosis of these clots, it requires that you do ultrasounds, and you're exposing ultrasound personnel, to radiology technicians, to be inside an ICU room, or there may be COVID all over the place. And of course, they wear their PPE, but it would be great to have a test in which you would say, well, this patient unlikely has a clot, we don't need to do an ultrasound. So that was kind of the philosophy of this study. So they included critically ill patients with SARS-CoV-2 infection confirmed by a nasal PCR. On every patient that was in their ICU, they did daily measurements of D-dimer, troponin, LDH, CRP, interleukin-6, fibrinogen, and some other labs. But these are the main markers. They did ultrasounds based on two clinical prediction tools. One's called the Wells score, the other is called the Dutch Primary Care Rule. The bottom line, these are scores that many ICUs use to decide if they're going to do an ultrasound on a patient that they may have a suspicion they have a DVT, and that's what they used here initially to screen patients. And the lower extremity ultrasound was, like I mentioned, was done with a positive screen. But now, interestingly, what happened was that these scores did not work very well because their sensitivity was extremely high on these patients, and on one of the scores, everybody was positive. So they ended up doing ultrasounds on almost, except for 2 patients, on every single patient that they enrolled in the study, which at the end of the day was good, because if this score would have ruled out a lot of patients, you really don't know how many of those patients could have had DVT. So I think this little glitch they had turned out in their favor. So what did they find? They looked at 72 patients with severe COVID-19, and 102 ultrasounds were performed. 17% of the patients had DVT, which is pretty high. And like I mentioned, the clinical screening tools were not useful because they predicted that everybody had a clot in their legs. So of all the biomarkers, and I'll show you a table in the next slide, but of all the biomarkers they used, the only one that seemed to discriminate patients with and without DVT was the D-dimer. And when they used a D-dimer cutoff of 3,000, that for those of you who are not, do not do clinical work or acute clinical work on acute patients, this is a pretty high number. But interestingly, every single patient with COVID-19 has elevated D-dimers. And we've seen this in our hospital. We do D-dimers on admission, and I have not seen one patient hospitalized, and I'm not even talking about the ICU, even the med-surg floor, with a normal D-dimer. So in this study, that when you make a cutoff of 3,000 nanograms per ml, the sensitivity of a D-dimer was 100% at this level, and specificity 50%, with a negative predictive value of 100% in their study. I always hate when I see 100% because I think the only thing that's 100% is that we're all going to die someday. Everything else is 99% or below. But anyways, they found 100%, but the positive predictive value was not very good. Only 20% of the patients with a D-dimer above 3,000 actually had a clot. But for their purpose of this study, they were really looking at the NPV, or the negative predictive value, as the main outcome. So here are all the labs they did, C-reactive protein, interleukin, et cetera, but the D-dimer was the only one that was discriminatory. And when you look at patients, overall, the median D-dimer levels were 2,500. With patients with DVT, it went from 3,000 to 30,000, and those without DVT, it went from like 600 to 3,700. So that's why they use that 33,000 cutoff. So their conclusions were that clots are common in patients with COVID-19, that using a D-dimer at a cutoff of 3,000 is sensitive to preclude further investigation with a Doppler of the lower extremities. And okay, this is a conclusion that they arrive. I don't agree with them too much. They said, considering the high risk for venous thromboembolism posed by COVID-19, they recommend aggressive anticoagulation in severe cases. So this study has not been really done yet. We are still waiting for a study that randomizes patients without evidence of clots to full anticoagulation to see if that impacts mortality or not. Okay, switching gears to another study, we're all hearing about the cytokine storm being the driver of death in these patients. So these authors, what they did is they set out to measure cytokine levels in patients with COVID-19 and ARDS, so this is severe COVID-19, and compare those levels to patients with ARDS or severe lung injury due to other causes. And what they found is that when they looked at TNF, this is IL-6, and this is IL-8, that patients with COVID-19 actually had lower levels of cytokines than other clinical scenarios. So this is kind of rebuttaling that theory, and I think we'll have to hear more about this. But their suggestion is that there definitely is a cytokine storm, but not very different from what they found to cytokine storms produced in other diseases or situations, and maybe focusing on treating this cytokine storm is diverting our attention to where the real problem may be. And speculating, the real problem may be clotting of the microvasculature that feeds those alveoli in the lung. So I just thought this is interesting because it throws a doubt, and I think it's in medicine and in science, it's always important to doubt your results and your hypotheses, because that's the only way that on the long term you're going to be weeding out all the incorrect ones and ending up with the truth in some of the questions that we pose with our patients. Okay, finally, this is a very interesting review that I do recommend, especially if you're a pediatrician, but if you just like physiopathology and immunology. This is a review from the National Academy of Sciences. I believe that's where it was published, that gives 5 reasons, hypotheses, most of them, of why children get less infection and less severe infections than adults do. So I'm not, because of time, I think, oh, we got a little bit of time. I'm going to summarize it. The most interesting one is number 1 in my view. And this is coronavirus associated with common colds in children may offer some protection. So how can this be? So they think it's due to 2 mechanisms. One is called viral interference. And what is this? It is that if you're already infected with a pathogen, the second pathogen has a hard time trying to get in. And there's quite a bit of evidence that this is true in many other infections. And there's some evidence that it is true in COVID-19. And they looked at studies in which children have other coronavirus, non-COVID-19 coronaviruses, and their risk of COVID-19 is much less than people who do not have the infections to these other pathogens. And then the other thing is immunological interference, in which if you get infected with a non-COVID-19 coronavirus, that does produce an immune response. And all of the coronaviruses have spike proteins in their surface. It's just a different sequence of amino acids in these proteins. But when you're getting an immune response to a non-COVID coronavirus, that may confer some immunity to a COVID-19 virus. So that's the other part of the hypothesis. The number 2, remember that the virus, when it gets into your cells, it needs to go through the ACE2 receptor. But to penetrate that receptor, that receptor needs to be cleaved, and it's cleaved by a host protein, which is called TMPRSS2, which is transmembrane serine protease that cleaves that ACE receptor and internalizes the virus. So what they found is that children have first less ACE2 receptors and less TMPRSS2 compared to adults. So that would give them some protection from infection. Of course, if they get exposed to a very high viral load, that might not matter, but they're exposed to a lower viral load, that might just save them from getting infected in the first place. And then 3 and 4, I'll bundle 3 and 4 into one, is that the T cell response in children is basically what they call a Th2 response, which is driven by certain particular interleukins, IL-4, IL-5, and 13. And these interleukins, when they tend to decrease or the number of ACE2 receptors when they're secreted. On the contrary, adults, they have a Th1 response, which produces interferon, not IL-4, IL-5, and IL-13. And interferon, although it is a molecule that has virucidal activity, it does increase your ACE2, the expression of your ACE2 receptors. So children would be protected from a severe disease because they would have a less inflammatory response when they get infected. And interestingly, children who have allergies, asthma, they tend to exacerbate these Th2 responses, and they may be even more protected against severe COVID-19. And the last one is that children, the main interleukin production is IL-6, which is a bad interleukin in the sense that it's pro-inflammatory. It's rare in children. As you're aging, this IL-6 starts increasing, but in children, you don't find too much IL-6, and you do in adults. So I'll stop there, and I thought that was a very interesting article discussing, why kids are less and have less infections and less severity, not meaning that they cannot have a severe infection. And those things are always fascinating to me. I always remember on the HIV epidemic, when early on they found that in Africa, a subset of sexual workers would not get infected with HIV. And it was astonishing because these individuals would get exposed to HIV on a daily basis. And that's when they found that they did not have the CCR5 receptor, which gave them protection. And that generated a lot of research to look at drugs that block that receptor, like Maraviroc, the one that we have today, and antibodies. So all these findings, although they seem very hypothetical, they usually lead to research that comes out with treatment or prevention interventions.
Great. Thank you for a wonderful presentation, as always. Do we have any questions for Dr. Mera?
Okay, I see Dr. Bryan, he's right. He's mentioning the Binex now is only approved for symptomatic, and that is true. But having said that, we had this discussion in Cherokee Nation, and I told them, well, okay, but it's probably better than nothing. And these tests, the problem is that they may have less sensitivity. So maybe in a non-symptomatic patient, the sensitivity will even be less. But here we're looking at, let's try to weed out some patients who may be positive and not expose the rest of the clinic. So I agree with you, Dr. Brown. It's probably not going to be approved for asymptomatics, but I think until we have something better, I think it's an option. As long as you understand, as long as everybody who's using it understands how to interpret those results.
Great.
So I think that that's an important consideration, and thank you for that. I don't know if you just got the email about IHS distributing 300,000 of the Binex tests to be used in private schools. So should the recommendation be that they only use them on children suspected of having COVID and showing symptoms, or as a screening tool for entry into school?
Well, I think you have to be careful because sometimes you are being audited or monitored, especially when you're giving tests, how you're using those tests. So if the test has a precise indication and you're going to have to be accountable for the use in that indication, then you will have to use it only for what it is approved. But then there's the clinical side of it. What do I do with the individual patient in my office or patients in my clinic? Then there you have a little bit more wiggle room to do what you think is best for that patient. A very similar example came up today in our clinic because many patients come in with respiratory symptoms and their COVID PCR is negative, or the Abbott NAT is negative. But the clinician thinks that it still could be COVID because they have all the symptoms or symptoms compatible with COVID. So they send the patient to quarantine, to isolation for 10 days. And a discussion came about this. And so technically, you cannot isolate a patient with a negative test because isolation is kind of a legally binding intervention in which you're telling that patient you cannot get out of your house. So you really can't isolate them. But as a clinician, you can, and on the individual patient, say, look, I think that you may have COVID, and although the test is negative, I recommend that you stay home. But it's not a legally binding recommendation. It's just your personal interpretation of the clinical symptoms plus the test, etc. I think here it's the same thing. If you're going to be accountable for how you use the test, then you can only use it for the indications that the test has. If you don't have that accountability, I think you can make your own decisions and use your best judgment in the middle of a pandemic in which we don't know many things and are lacking things that we need. I mean, that's my personal opinion.
Is this a tool that a school nurse could use, or would this need an actual provider to administer, actual licensed medical doctor, nurse practitioner, advanced practice?
I believe it's, okay, maybe Harry knows more about this. I believe it's CLIA waived, but you still have to have someone trained doing it. I'm not sure this is like a home test thing that you can give to anybody, but I'll let Harry jump in there.
Yeah, it is a CLIA waive test, but it still has to be used in a healthcare setting. And it does take, a little bit of training by the operator. But the nice thing about the test is that it can be used in a CLIA waive setting at the point of care. And, it doesn't have to be a lab tech performing the test.
Okay. Thank you.
Any other questions for any of the panelists today? If not, there's the survey in the chat. If you will click on that link and fill out the survey, that would be appreciated. You will need to do that for to receive the continuing education credits if you're applying for those. Other than that, I have nothing else. You all have a great afternoon.
Bye-bye, everyone.
Bye. Thank you.